All right. Good evening, everyone. I'm just going to stall a little bit and do a little introduction while I'm allowing everybody to join the live feed. My name is Dr. Adreinne Neithardt. I'm a reproductive endocrinologist and infertility specialist. I'm with Delaware Institute for Reproductive Medicine, and we are located in Newark, Delaware, Milford, Delaware, and also Chatsford, Pennsylvania. We are a partner clinic with Boston IVF, and I also see patients remotely for our Boston IVF New York location out of Albany. So, welcome to everybody who is able to make it tonight. And I'm really happy to be able to be here for this live Facebook question and answer during National Infertility Awareness Week. I got as close to orange as I could get. So that's my shout out for tonight. As we're going along, I can't see anybody here, but I will see your questions as they come up through the chat. I will try to answer as many questions as I possibly can. Some of them have been submitted previously, some will be submitted live through tonight. If I can't get to your question, I apologize, but I will try to do my best to answer as much as I can. All righty. So we'll start out with some questions that I have that were submitted previously. And a specific question that came in was, it was phrased as, do you need to have prenatal care if you're freezing your eggs and saving them? And to try to reframe that, so to make sure I'm getting at the right thing, I wouldn't necessarily call it prenatal care, which we usually refer to once you are actually pregnant, but preconception care, I think, is important. So, there's a lot of emphasis on what you do once you are pregnant, but leading up to it can be just as important in a lot of circumstances. When someone's getting ready to freeze their eggs, or getting ready to start trying to conceive, I think it is important to try to take a look at different factors. So you're getting ready to freeze your eggs or conceive. For those 3 months prior to conception or prior to freezing your eggs is when your eggs are under the most influence of the environment. And so trying to be the healthiest version of you possible before you do those things is going to help. Our eggs have been with us since we were born, so we don't have the benefit of making new eggs from fresh, but our environment can affect the quality of our eggs, our ability to get pregnant, etc. So what do I mean? What kind of prenatal care? Well, treating any underlying medical problems, uncontrolled diabetes, hypertension, an autoimmune disease, anything like that in our general medical health, if it's uncontrolled especially, may affect the quality of our eggs and our outcomes with getting pregnant and having a healthy pregnancy. Avoidance of toxins, tobacco smoke, nicotine, whether it's in vaping products, whether it's in cigarettes, chew gum, whatever way you want to reduce, if not eliminate your exposure to that prior to trying to get pregnant and prior to freezing your eggs for at least 3 months. We do know nicotine can concentrate in the fluid around the eggs, and so it can affect outcomes. The same is true for men, so I'll put a little shout out for there too. That nicotine does affect your sperm and your sperm health and quality. So ideally stopping it, but it's also dose dependent, so decrease as much as possible. Try to limit alcohol, try to avoid cannabis. We have less information on the effects of cannabis on our sperm and eggs and fertility outcomes, but it is a toxin. And we do know there's receptors at different areas around the body, including in the testicles and including in the ovaries. So trying to limit or eliminate your exposure to it would be beneficial. I usually tell women to take a prenatal vitamin or at least folic acid for 3 months prior to freezing your eggs or before trying to conceive, trying to get to a healthy weight. That doesn't mean crash dieting, but again, trying to be the healthiest you possible leading into this. And of course, have a discussion with your OBGYN. Come to see a reproductive endocrinologist before you actually want to freeze your eggs to talk about it, to try to get an assessment. So I think that was actually a really good question to start things off with tonight. So I have another question, and this kind of goes right into this. Someone is asking that they're 35 and single. Is there a reason I can't do egg freezing at this stage? Absolutely, there's not a reason that you can't do egg freezing at this stage. We do know that the younger you are when you freeze your eggs, the better the outcome, meaning the more likely those eggs are going to result in a live birth, which is what you want. As we reproductively age, we need more eggs to get that one live birth. And we're more likely to get more eggs the younger we are. So it's a bit of a double-edged sword. So ideally, I'd love to see people freeze their eggs under the age of 35, but we know we have really good outcomes up till 37 or so. And we don't have there's not an age limit really, as long as you've got a decent ovarian reserve, that we won't freeze eggs anymore, but becomes much less effective. And you need a lot of eggs 40 and above. And after 43, unless there was extenuating circumstances, I'd be very unlikely to recommend freezing eggs. So I would say absolutely, if you're 35 and single and not sure what your reproductive plans are, now's the time to have a conversation about that. So there's a question here about, do you have to use birth control for an IVF cycle? We deal with this all the time. And it's probably going to get a different answer for a different clinic. There's various reasons why we may use either the birth control pill, but there's also other forms of like progesterone only or other forms aside from just the straight up birth control pill we can utilize if we need to one, be able to schedule your cycle appropriately. And there are some advantages for a short period of time using a birth control pill or a progesterone only pill to help kind of sync up the follicle size and get a more uniformed response. Now, it's very individualized. There are women who cannot go on combined birth control pill, whether they don't tolerate it well or for medical reasons. And there are alternative ways around it. It's really going to depend on the clinic and the location of the clinic that you're at, how much flexibility they have, because so much goes into an IVF cycle as far as scheduling and having to have a surgical procedure with the laboratory, anesthesia, the doctors, and everybody available. There are some locations that have to kind of group patients together and may have less flexibility to do it right off your natural menstrual cycle. But don't let that scare you away. There are options. Whether it means starting at a different phase of your cycle or using a different medication to help schedule it. There's a question here about thoughts on PGA testing in someone over the age of 40 who yields a low number of blastocysts. And this question about, do you test or do you not test? This is a really excellent question, and I think it's not a straightforward answer. And I think it probably depends also on you and your risk tolerance. We know that the people who can benefit the most from PGT-A, and I should explain, PGT-A is pre-implantation genetic testing for aneuploidy screening. Big mouthful. What it is, it's genetic testing of your embryos before you transfer it back to the uterus to look for whole chromosome abnormalities. And a whole chromosome abnormality means an embryo that's missing a chromosome or has extra copies of chromosomes. PGT-A is not looking for specific disease. And the reason why this is offered and talked about is that we know as we reproductively age, as our egg gets older, a higher percentage of embryos that are created have an abnormal number of chromosomes. And this is one of the factors that really decreases pregnancy and live birth rates in women as we reproductively age. And so it's estimated if you're over 40, the majority of the embryos you make may be chromosomally abnormal. And then depending on what lab you look at, you might get quoted a different number, but we know it's more than 50% typically. And so in a perfect world, if you have blastocysts, if you have 4 blastocysts, yes, doing the testing and being able to pick the embryo with the highest implantation potential gives you the best chance of having a live birth. But the reality of the situation for a lot of women in this age group is that we don't make a lot of eggs or embryos at one time. And then you're weighing, geez, do I test that one embryo I have? Or do I put it back inside my uterus and take a chance and see what happens. Well, it's not a clean cut answer because PGT testing is extremely accurate, but it's not perfect. It's based on testing of a few cells from the part of the embryo that's going to become the placenta. And most labs will tell you that about 2% of the time the testing isn't accurate. Doesn't mean that the lab test was wrong, but it may mean that those cells that they were tested aren't reflective of the embryo. So there could be a 1 to 2% chance of a live birth from an embryo that's considered aneuploid. And some studies show that that's probably even lower than that, maybe less than 1% if it's a whole chromosome abnormality. And so for that reason, some people really question, especially if it's a small number of embryos, do I test or do I transfer that embryo back? And this is where I think it comes down to your personal risk tolerance. And every couple I talk to is a little different. And I have people express to me that they would rather test and know right then and there that the embryo is unlikely to make it to a live birth rather than going through a transfer and potentially a miscarriage. Because we know with an untested embryo in your 40s, the miscarriage rate is very high. It can approach 50% by the time you're closer to 45. Starts out probably at 25% or so at the age of 40. And that emotionally and physically is really difficult. But then on the same vein, I have other people express to me that, they can't walk away from this without doing a transfer. And the thought of spending the money and doing the PGT-A testing and not having anything, they would rather, if they make a blastocyst, transfer it back to the uterus and then go from there and see what happens. You always have the availability of prenatal genetic testing, meaning testing the fetus once you're pregnant to make sure that the chromosomes are normal. So it is controversial. There isn't a right or wrong answer. It's a good discussion to have with your physician and to really weigh those personal risks and pros and cons there. There's a question about the advantages and disadvantages of ICSI. A lot of hot button topics here are already tonight. So ICSI stands for intracytoplasmic sperm injection. It is when in the laboratory during IVF where a normally shaped moving sperm is selected and injected into the egg. Doing ICSI does not guarantee that fertilization is going to occur. It is typically used, or at least initially when it was first kind of invented, was used to treat male factor infertility. So if you had very low sperm counts, that you knew you were unlikely to get good fertilization rates just by doing conventional IVF, where you just put the moving sperm around the egg in a little drop of media. And that's where ICSI started. It's expanded, and it can be done for cases of low egg yield, couples with prior poor fertilization, either no fertilization or lower than average fertilization rates with conventional IVF. There are clinics that do ICSI for everybody, and I think some clinics have just developed into that way of practicing. And so again, it's one of those where there's not always a right or wrong. I think sometimes there can be advantages if there's normal sperm, especially in a couple who've conceived together in the past, in doing normal insemination, in the fact that when you take the eggs out, they've got all their cells around them. They may continue to mature even in culture for a short period of time, and it allows kind of natural selection of the sperm for fertilization. But we certainly know that sometimes, especially with unexplained infertility, we have less than optimal results. In a perfect world, fertilization rates with ICSI and conventional insemination should be equal. We do see it a little bit higher with ICSI, and there are isolated couples that sometimes we don't anticipate that may have very poor fertilization with conventional IVF, and I think that's why some clinics go right to ICSI. Sometimes there could be a financial cost to that if your insurance doesn't cover it, unless there's a male factor. When you look in the literature since the beginning of IVF, there's a slightly higher incidence of urogenital abnormalities, like especially in male children where ICSI was done. But this data is really confounding because, especially historically, most ICSI cases were done for male and especially severe male factor infertility, which is probably confounding that outcome. Most of us agree that ICSI is a safe option. And I definitely think it's something to discuss. And again, it can be very dependent on the lab you're working with when you're going through IVF and what their recommendations are. I have a question here about in an LGBTQ couple, welcome, asking about options, short of going to IVF or before going to IVF. So again, it's all very person dependent. But if I take, mentioned here, healthy 32-year-olds. So if I have a young, healthy female with no history suggestive that there would be difficulty conceiving, and there's no history of infertility, meaning you hadn't tried previously or hadn't had prior sperm exposure that hadn't resulted in a pregnancy, it's very reasonable to do intrauterine inseminations first. If you look at success rates with IUI, in the infertile population, it's not great. We know that it's an inefficient process, and human reproduction is pretty inefficient too. But if you look at women with unproven fertility, with normal menstrual cycles, evaluation looks good, you have a really decent chance within 3 IUI cycles of being pregnant, having an ongoing pregnancy. So, and you can do that with your natural cycle. You don't necessarily have to take fertility drugs. And in fact, if you look at women using donor sperm who have regular menstrual cycles, and you look at success rates with donor IUI, with like using Clomid or letrozole as an oral fertility drug versus just timing it with your natural cycle, whether you're doing a trigger shot or not, the success rate is the same. I think monitoring in a trigger shot is often helpful, more for timing, because timing is the biggest part of all of this. But you definitely have options, don't have to feel like you have to go right to IVF. I think it can be really hard currently in these days in that donor sperm is so expensive. If you're using an anonymous sperm donor, even if it's not an anonymous sperm donor, it can be very expensive. And I think that's sometimes what turns people towards IVF, because with IVF you may get more than one embryo from one vial of sperm to use to be able to have more than one child. So again, I take all of those things into consideration, both partners, who wants to carry, who wants to use their eggs. Do you want to do reciprocal IVF and carry each other's eggs or embryos? How old are you? What fertility issues do you have? So it's worth a discussion, but don't feel like you have to jump right to IVF. Let's see. Other questions we had. Someone had asked if spotting 1 to 2 days before a period indicates a hormone imbalance. And I will say just first off that spotting is really common before full flow, and in the vast majority of cases, it can be normal. We do see this happen more frequently and maybe longer before you start full flow in women with endometriosis. And I don't know that it's necessarily a hormone imbalance, but we know that with endometriosis, you have resistance to progesterone. So as your progesterone goes down before you get your period, you may start spotting. Your lining might start breaking down a little bit earlier. It certainly could be a sign of dysfunctional ovulation, quote unquote, hormone imbalance, meaning the progesterone's not staying elevated long enough. It could also be a sign of like polyps or fibroid inside the uterine cavity. So, and those are all things that we would rule out with an infertility evaluation as much as we can. Endometriosis is a longer discussion. You can't necessarily rule that out with just a standard evaluation. But as far as looking at the cavity, looking at the polyps, making sure we optimize ovulation, those are certainly things that we can optimize. Another question I had that I think is going to pertain to a small percentage, but I wanted to make sure I answered this because somebody took the time to submit it before the Facebook Live event. The question is that the person is saying that their mother took DES during her pregnancy with her, and then is asking, is her daughter, so the granddaughter of the woman who took the DES during her pregnancy, is she going to be infertile? DES was a medication that was given to women during pregnancy a long time ago, maybe back in the 50s, and sadly found out that it increased the risk in in female children born from women who were exposed to DES. It can increase their risk of having vaginal or cervical cancer, increase the risk of congenital abnormalities of the reproductive tract, which could cause that woman to be infertile. There aren't a lot of studies on the third generation. So when you're looking at now the granddaughters or grandchildren from that, very few studies. Most are conflicting. Most are favorable. I did see a study that showed that there might be an increased risk of menstrual irregularities in the children of women who are exposed to DES, but there really isn't much out there to suggest that they would be infertile. So again, I think it's a good thing to note in your history to your physician, but it doesn't mean infertility for your daughter. So there's a question about DNA fragmentation of sperm, and specifically in the setting of a normal semen analysis. None of these questions are quick, easy questions to answer. DNA fragmentation index, or DFI, is trying to measure the percentage of the sperm that has fragmented DNA in it and is a sign of oxidative stress. We're hearing more and more about this recently. It has been seen in association with maybe unexplained infertility, poor fertilization rates, poor embryo development, potentially recurrent pregnancy loss. I think we're still really trying to figure it out, though. We do know that you can have an elevated DFI or fragmentation index even with a normal semen analysis. And so I think anyone, in my mind, anyone who was interested in getting this information, I think it's easy enough to do. It's usually not covered by insurance, but there are laboratories where you can have a kit sent home, collect the sperm, send it off, and at least get this information. The question is, what do you do with it? Which is a longer answer. In general, people who I offer DFI to, sometimes in the setting of unexplained infertility, especially if someone goes through IVF and has unexplained, like poor embryo development or poor fertilization in the setting of a normal sperm count, that may be reasonable to check. Couples with recurrent implantation failure or recurrent pregnancy losses would be a discussion I would have, or male factor in infertility. Because it's not covered, it adds just another burden to patients, though, as far as just increasing cost. Things that we know that can help improve sperm fragmentation, and the person here mentioned that this was also in the setting of someone who has insulin resistance. So we know treating any chronic medical problems in men, especially uncontrolled diabetes, hypertension, obesity, all of those things can increase or decrease the quality of your sperm. And trying to optimize that is going to help. Men make new sperm within 3 months. You can make some significant lifestyle changes and may impact the quality of sperm health. The use of antioxidants. It's a little controversial. Some people believe it doesn't do anything. Some people believe it helps. Very little downside to using it. We know antioxidants help with oxidative stress, so theoretically it could help reduce the amount of sperm that's fragmented. More frequent ejaculation around the time of ovulation or right before giving a sample for an IUI or IVF. So in the past, we'd say, wait 3 days or more, of abstinence before giving your sample. We now have evidence that if you have a shorter ejaculatory interval, 24 hours, say, that younger sperm is less likely to be fragmented. And then finally, there's some evidence that if you take a biopsy of the sperm from the testicle, and so you go back and get kind of immature sperm, they're less likely to be fragmented. This obviously is our kind of last case scenario, and I think it's been demonstrated more research than in clinical practice routinely. So it would be a very specific situation before I'd recommend something like that. But again, I think if you're interested in getting the sperm fragmentation, there really isn't a reason why you shouldn't be able to request it. And as I said, there are labs. SCSA Diagnostics is one that will allow patients to order this test for themselves and then have a discussion with your physician afterwards. Let's see what else we have. Somebody asked how long it would take to get an appointment with me if you're in Christiana. It does not take long at all with myself or any of my partners. So just give us a phone call or fill out the form online and we'll get you scheduled very quickly. Um, it's another question here about PGT-A. It says, is there an ability for an embryo that is monosomy or trisomy to be able to self-correct if it was transferred? Again, these are really, really in-depth questions. Monosomy and trisomy refers to the chromosome number in an embryo. Monosomy means it's missing a chromosome. Trisomy means it has an extra copy of a chromosome. And so the short answer could be potentially an embryo could self-correct, and especially if not all the cells are abnormal. And when you do PGT-A, you're only looking at, maybe 6 cells out of an embryo that's hundreds and hundreds of cells. So if it's mosaic, which you might not be able to demonstrate, and that aneuploidy was just maybe confined to the placenta, is it a possibility that it either self-corrects or that the majority of it was normal and it was going to go on? But there are some pretty good studies out there looking at that was blinded, transferring embryos that had been tested and we didn't know the results, and afterwards it was blinded or unblinded, that showed that really if you have a whole chromosome abnormality, a monosomy or a trisomy, that the chance that you're going to have a healthy live birth is under 1 to 2%. So we usually say under 2%. It's probably even under 1%. So you just have to keep that in mind. And a lot of clinics will not transfer an embryo that has been documented to have a monosomy or a trisomy, a whole chromosome abnormality, for a whole other various reasons. But once you know that, sometimes it'll also depend on what embryo is at or what chromosome is abnormal. So it's really important to have a discussion prior to doing the testing, and then again after you have the results about what an individual chromosome abnormality could mean if it resulted in a live birth. Because we're not just talking about getting pregnant or not getting pregnant. We're talking about maybe a pregnancy that could occur, but it's going to be a miscarriage. And is that miscarriage going to happen in the first trimester, or is it going to happen later in pregnancy that puts mom at physical risk as well as the emotional risk? Or could it be a baby that's live born that then doesn't live? And those are all really important questions to ask. Someone's asking if we treat patients with polycystic ovarian syndrome, otherwise known as PCOS or PCOS, and absolutely. At DIRM, we will see women who either are suspected or have known polycystic ovarian syndrome, even for medical management. Even if you're not interested in conceiving right away, we do see you. So please give us a call. Here's a good question about how long does it take from your first appointment to get started with IVF? Again, some of this is going to depend on the actual clinic that you're being seen at and what the volume is like at that clinic. It also depends on how long it takes to do a workup, get insurance authorization, and get going. I will say that at DIRM, most people, if they come in, have an initial visit, do their workup the following month, probably within 3 months can be moving forward with an IVF cycle. But it's really going to vary because things also come up. And what I always tell people going through this journey, it's not linear. For some people it is. You start at A and you get to Z and it's a straight path. But for the vast majority of people, it isn't. You start making progress and something comes up, whether it's something else in life or we find a polyp or a fibroid or something else happens that needs to be addressed along the way at any step of the way. And it can be really frustrating. There's turns and you go backwards sometimes before you go forwards. And I think aside from just having to deal with infertility in general, the waiting game and how long this takes really adds to the anxiety. We would do our very best to keep things as efficient as possible while also being thorough and making sure you are taken good care of. Now, if I see someone for a first visit and they know they're going to go to IVF, it's a little easier to expedite it than someone who is just here, not sure what they're going to do, has to do a workup and is kind of going in more of a stepwise fashion. Um, Someone asked a question about high prolactin levels in the setting of a normal brain MRI. Um, and other things in this question. I'll try to answer as much of it as I can. So hyperprolactinemia is when you're usually coming from your pituitary gland, some of the cells there that normally produce prolactin, it's usually the hormone that's produced after you deliver to induce milk production for breastfeeding. And sometimes those cells can just kind of over proliferate and they produce excess amount of prolactin. Some women will have symptoms, and that's what takes them to be evaluated. They could have milky discharge from the breasts, but it also can contribute to irregular or absent menstrual cycles. It can kind of shut down the whole system. Even with the normal, we always do an MRI because we're trying to make sure there's not something large or that could be dangerous going on within the pituitary. But the vast majority of these are caused by microadenomas, which are the very small overgrowth of these cells. Sometimes it's picked up on MRI, sometimes it's not. But even if you don't see it on MRI, it's probably still there. It's just too small to actually see it. There is a medicine called cabergoline or bromocriptine that suppresses prolactin. And so for somebody who's trying to get pregnant or having really absent or irregular menstrual cycles in the setting of high prolactin, using that medication to normalize it may help your cycles normalize, may help you ovulate so that you can conceive. And so, that to answer that part of the question, prolactin is generally part of general, for most of us, screening for infertility, especially in the setting of irregular menstrual cycles. So someone asked a question about karyotyping results. A karyotype is usually done on, the male or female, the sperm and the egg carriers in certain situations, especially with recurrent pregnancy loss, sometimes with unexplained infertility, or if there's any other suggestion of significant abnormality, like very, very low sperm counts. And a karyotype is looking at your chromosomes. What it's mainly looking for is any rearrangements or translocations where little pieces of the chromosomes are kind of out of order. And this person asking a question about what do you do with these results? So, and I hate to say that it depends on what the results are, because it's all going to be different. Most people who have a translocation are absolutely fine, healthy adults and can go on and have children. What happens is when you have a rearrangement, more of, if it's on the female, more of the eggs, if it's on the male, more of the sperm are going to be unbalanced. They're going to be missing little pieces of their chromosomes. So the miscarriage rate is higher. It's not 100%, but it's much higher than it would be if you didn't have that rearrangement. And if that's the situation, you can do IVF with something called PGT-SR, which kind of amplifies that region where it could be unbalanced to make sure you're selecting an embryo that has the right number of balanced chromosomes to put back in the uterus, and that significantly decreases miscarriage rates. Now, if the karyotype is not for this, what are other things that we find? A woman who has ovarian failure or never had a menstrual cycle, sometimes we'll diagnose with Turner syndrome or mosaic Turner syndrome, where there's only one X chromosome, and we can't change that. And for a lot of people, especially if they're not having periods with Turner syndrome, we can't get eggs. And so then we're talking about using an egg donor. And there's various other chromosome abnormalities. So karyotype results are not one thing. I think you need, if you had that and you have an abnormal karyotype, you need to talk to a genetics counselor, and then you need to talk to an REI about what this means for your reproductive health. Someone asked again for the name of the lab. The lab that we use, and it's called SCSA Diagnostics. I'm not affiliated with them whatsoever. We happen to use them. You can have a sperm fragmentation testing done with them through a doctor's office via an order, or a patient can request the kit themselves, and it's a reputable lab. Someone is asking saying they were just diagnosed with endometriosis and should they come to see a fertility doctor sooner rather than later? Well, my answer is always going to be yes, because I think and it doesn't even mean that we're necessarily going to do anything, but knowing what your situation is, how severe the endometriosis is, what timeline till you want children, this is going to help you plan things out the best. So I would say, yes, it's worthwhile having a conversation. Um, there's a question here about, I think it says chronic endometriosis, but I think it means chronic endometritis in the setting of someone who's doing an embryo transfer. Um, Chronic endometritis is when on a biopsy of the uterine lining, the endometrium, there's evidence of plasma cells, which are an indicator of inflammation. If there's very few scattered plasma cells, most people agree that that may not really be diagnostic of chronic endometritis. But if there's a prevalent number of plasma cells, most of us do treat, and it sounds like you were treated and you still have persistent um, plasma cells. And we have very little data to really guide us. If this is in the setting of recurrent pregnancy loss or recurrent implantation failure, I would do my best to try to clear it as much as possible before the FET. And one thing you could consider is doing a more specific test for endometritis called the ALICE or EMMA, where they try or a culture of the lining of the uterus to try to identify what bacteria it is, because that may be able to help you have more targeted treatment. But if you've already done that and you've treated it and you're down to just a scant number of plasma cells, I don't think it's unreasonable to consider doing a transfer at that point. But definitely, I don't know your whole situation, so please make sure you discuss it with your REI. Um, Here's I think a good question to ask. So someone posted that they're 35, the husband's 42. They've been trying for about 4 months. Their OBGYN said to wait. I feel like I shouldn't. So first off, the official guidelines are unprotected intercourse for 6 months. If you're over the age of 35, you should go see an REI or have an evaluation, and over a year if you're under 35, if there's no other signs of any issues. Meaning, if you have irregular menstrual cycles or pain or anything else, you don't have to wait that length of time. I also don't think you have to wait if you're worried about it. It's 4 months now. By the time you get an appointment, you get seen, you start to have some testing done, you're going to easily be at that 6 month mark. So if it's something that's worrying you, it's very reasonable to come in and have a conversation about what an evaluation even entails, and you can decide how much of it you want to do and how much of it you want to defer. So if you're worried about it, I'd say come see, make an appointment. Um, let's see what else we have. Another question about a semen analysis that has good motility, but the sperm isn't very forwardly progressive. Do you do a DFI? What do you do in that setting? So a couple things without knowing all the details. One semen analysis, I never make wide sweeping conclusions because men are constantly making new sperm. You're going to see ups and downs. So I always get more than one data point to try to get an idea of where the sperm is for most of the time. I think having an evaluation with the urologist, if there's any abnormalities, is important to make sure there's nothing serious that's being missed. And certainly the DNA fragmentation can be part of that, especially if you persistently have, this abnormal motility. So I think it's very, very reasonable thing. Um, a technical question here. Someone asked about, if their period falls on the weekend, what do you do as far as scheduling? So most of us, day one is the first day of full flow. If it happens after like 5 o'clock in the evening, we consider the next day, day one. Every clinic that you're working with might have different ways of handling period starts on the weekend, but the vast majority of them, what they say is just contact us first thing Monday morning, because you can get in on the second, third, or fourth day. So even if you got your period, Saturday, you could call Monday, still come in Monday or Tuesday. So that's how most of us handle it. DIRM and most clinics also have somebody on call, to answer questions after hours. The portal's not a great way for any emergent after hours questions, but during the day, that's a great way to ask your questions also. Um, Someone's asking a question about a second opinion, and I think it means a second opinion even within the group. And I think most both at Boston, I've done this before, and at DIRM, yes, if you want to seek a second opinion, whether it's within the group or even if it's outside of the group, I usually encourage people to do that. And it doesn't mean you have to leave the physician that you're working with, but sometimes just getting reinforcement that you're on the right track and that there's nothing that you're missing is important. And I think that's a very reasonable thing to do. I think, let me see what time we're at. Oh, okay. Just making sure I got everything. So, question here was how does one's diet affect the chances of a successful chance of getting pregnant through IVF? There isn't one magic diet. I think in general, and I alluded to this a little bit at the beginning in talking about preconception care and getting ready for IVF or getting ready to conceive and making yourself the healthiest you possible. So, a diet that's high in lean protein, rich in fresh fruits and vegetables, your good fatty acids like olive oil, nuts, fish, and low in processed foods and simple sugars. That way of eating, which is the Mediterranean kind of diet, usually comes out on top with a lot of different health indicators. There's no indication that you have to give up, unless you're diabetic or there's another medical reason that you have to give up whole categories of food. But it's just saying, okay, if I eat this way most of the time and I combine that with moderate activity, it could be walking 3 or 4 times a week for 30 minutes. Even if this doesn't result in weight loss, metabolically, you're going to be healthier going into an IVF cycle and ultimately going into your pregnancy. But I wish I could say there was one magic way to eat that was going to make everything better. Someone asked, what's the difference between PGT-A and PGT-SC? And I think they're referring to SR. PGT-A is standard aneuploidy screening, so it's looking for missing or extra copies of chromosomes within the embryo. SR is segmental rearrangement. It's when, as I mentioned, when I talked about a karyotype before, where some people carry like a rearrangement in their chromosomes. So we would only do PGT-SR if you know you have a rearrangement and it's planned ahead of time. The lab that's doing the PGT analysis knows where your rearrangements are on your chromosomes, where the possible breakage points can be, and it allows them to better identify an embryo that might have small rearrangements in it to make sure there's a balanced number of chromosomes. So it's specifically done just in those situations. And then there's PGT-M, which is when a couple, one or both, have a specific gene mutation that could cause a disease. So example, each person carries the gene for cystic fibrosis. It's recessive. And if they each carry one, there's a 25% chance that a baby is going to get both copies of that gene and be affected with the disease. So if we know that a couple has 2 copies of that or any other disease-causing mutation, you can screen the embryos for that specific mutation to decrease the chance that you're going to have a baby affected with that disease. So PGT-M is when you know there's a specific genetic disease that's caused by a specific mutation. So there's a question here about hydrochloroquine helping with miscarriage rates. And the person who's asking this, especially in the setting of lupus, I can't say I'm completely up to date on all the literature. The other name for it is Plaquenil. There is some evidence, though, that we know that it's it is anti-inflammatory, and when you're used for a rheumatological disorder, there is favorable, I guess, a favorable profile for using it preconception as far as also helping keep your disease under better control. I know there have, and I can't quote them specifically, I know there have been some studies looking at it even outside of people with autoimmune disease and whether or not it'll help with recurrent miscarriage. I don't think the evidence is very robust. I generally don't prescribe it unless someone is on it in your situation for lupus, for a mixed connective tissue disease, then I really do think it is favorable. Or if there's any other reason a rheumatologist wants to use it, I don't empirically prescribe it for recurrent miscarriages, but I do think there are some REIs that do. Um, Yes, we do. Sorry. Someone asked if we see patients in Pennsylvania. We do see patients in Pennsylvania. We are all licensed in Pennsylvania. So we can see you either in person. We have an office in Chadsford, right on 202 on Concord Pike. But we also can do a virtual visit with you. So absolutely. Um, some of these questions are getting more specific. There is a question here in somebody who has PCOS, is also in the setting of a kidney transplant. And this is a lot more complicated. And I think it really requires a multidisciplinary approach, meaning an REI, a maternal fetal medicine in high risk OBGYN, and of course your transplant or doctor or nephrologist. There are reports of people having babies after kidney transplant, but this is really complicated and well beyond the scope of this discussion. But I would encourage you to come in and have a discussion with someone. Absolutely. There've been a couple questions in here about Omnitrope, which is growth hormone, which is also a very hot button topic right now. Um, we do use it in select situations here at DIRM. Historically wasn't a huge fan of it. I think, we recently looked at the literature at Boston IVF, and there may be certain situations and certain patients where it's warranted to utilize. And this has been an internal discussion at Boston IVF in general. So I'd really encourage you to speak to your physician there about it, because this has recently come up in discussions at Boston and may be a possibility for you. Um, all right. I think we got most of these questions here. I really appreciate everybody coming out. Hopefully you got some good information. Hopefully it all made sense. Remember, any one of us at DIRM, at Boston IVF, would be really willing to sit down and talk to you about your specific situation. It's a really tough thing that you're dealing with, and I think it's important to be able to have an open conversation about it. So, thank you so much for joining us tonight, and hope everybody has a good remainder of your week.